Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Understanding Adolescent Self-Harm and School-Based Interventions, presented by Ryan Kidder. My name is Coffee Dixon, and I'll be moderating the session today. I'll cover a few housekeeping items before we begin. Following the presentation, we will have time for questions. Please use the Q&A feature in the webinar toolbar to submit your questions, and we will cover as many as time allows. The webinar will be recorded, and the link will be shared in the follow-up email after the session. Instructions for how to claim continuing education credit will be uploaded to the chat section and sent in the follow-up email after the webinar. So without further delay, it's my pleasure to introduce our presenter. Ryan Kidder is a social worker for the Scanlan Center for School Mental Health Clinic, facilitating individual and group counseling. He specializes in working with clients experiencing intense emotions, including those who engage in self-harm behaviors and suicidality. He has experience in supporting clients with anxiety, depression, challenging behaviors, psychotic disorders, and intellectual disability. Ryan primarily uses dialectical behavior therapy, DBT, in his approach to therapy. Before working at the Scanlan Center, Ryan was a therapist at Family Systems Therapy and Counseling Services, a student and family advocate for the Iowa City Community School District, and a therapist for the University of Iowa Healthcare. Welcome, Ryan. I'll turn it over to you.
All right, thanks, Coffee. Wanted to give a shout out to a few students who contributed to this, Zeus, Dahlia, and Margaret. I do not have any disclosures that I need for relevant commercial interests in regards to this topic today. So here are some of our learning objectives. We're going to learn some common functions of self-harm behavior. We're going to increase people's knowledge of distress tolerance skills from DBT, gain advanced knowledge of mindfulness skills from DBT, and enhance validation skills. So to kind of kick this off, I know typically who I am when I present. I want things to be more interactive, and I know we're kind of limited by using a Q&A feature here. But I just want to hear if people wouldn't mind throwing some things in the Q&A. What are your initial thoughts when it comes to your experience with working with individuals who engage in self-harm? What are some reactions, assumptions, something that's helpful, something that's not been helpful?
One comment is I've been there and I want others to get through it too.
Yep. So being able to relate.
The difference between non-suicidal self-harm versus suicidal self-harm.
Yep. And when that overlaps sometimes too. Yep.
Behavior is communication. Self-harm is no different.
Yep. Communicating to self and communicating to others.
Reducing shame and negativity.
Big part of DBT and mindfulness is letting go of judgment if we can. And again, easier said than done.
Some clients have a difficult time using techniques in the moment to prevent injury.
Absolutely. We're asking our clients to sit with in distress and not act on that emotion.
Not being able to relate is a struggle because they don't think we understand.
Mm-hmm. And I'm hopeful that the validation skills that we talk about might be helpful as well. So I know there's probably some more comments coming through, but for the sake of time, I'm going to keep rolling on. Thank you. All right. So what is non-suicidal self-harm? So I'm going to distinguish or kind of throw out non-suicidal self-harm, non-suicidal self-injury, kind of in the same kind of context. Again, it's purposeful harm that is done to self. Typically, what we see is cutting. Sometimes we see burning. Sometimes we see individuals hitting themselves or whatever is done to kind of hurt an individual self on purpose. And rates are higher in adolescence, and we tend to see kind of some simmering out as people kind of reach adulthood, but not always as well. And there are some findings that the longer that an individual engages in self-harm, the more likely they are to their increase in suicide attempts tends to increase. So again, the longer duration of an individual engaging in self-harm leads to an increase in suicide attempts or the increase in severity of the non-suicidal behavior. Again, we're looking at poor health outcomes for individuals that do engage in this type of behavior. And engaging in this self-harm at an earlier age can also be associated with frequent lifetime non-suicidal self-harm and an increased number of suicide attempts. Also, co-occurring substance use, including cannabis as well. So here's some kind of older data on some prevalence, like how the rates of suicide attempts, but also individuals that engage in self-harm. One thing to take note of here, and on the right side, is how many individuals in Iowa from the Iowa Youth Survey reported in regards to thinking about suicide, but also self-harm. And unfortunately, in 2023, Iowa passed a file that, well, some people might think it's unfortunate as well, but like this used to be just a blanket survey that was given to all of our students in public education in Iowa. But now moving forward, we need active parental consent in order to obtain this data. So a recent study that I found in regards to self-harm, in 2026, they did this meta-analysis of 42 studies and 12 in regards to 12 high-income countries over a 20-year period in regards to self-harm. So from 2000 to 2024. And based on healthcare encounters, they saw a 3.5 relative annual increase in self-injury over the study period. So what we're seeing here from 2000 to 2000 and on is this steady gradual increase in individuals engaging in this type of behavior. And typically what we see is there's more of a representation of females engaging in self-harm behaviors versus males. So here are some risk factors for individuals who tend to engage in self-harm type of behavior. Academic stress, bullying, peer victimization, reputational aggression, relational aggression, attentional issues, and other factors like maybe home life isn't so great, right? Maybe parents are divorced, there's neighborhood safety, low self-esteem, emotional distress. So if people, I'm going to throw out a quick question here, and you can use the Q&A function. What do you people think is a common theme of all of these risk factors that are listed?
Anxiety,
Yep.
socioeconomic status,
Yep.
external influence,
Okay. So a lot of things that are done to that person.
comorbid mental health concerns,
Hmm.
relational connections.
Yep. Absolutely. When I look at this slide here, I think in the context of trauma, right? These are often things that are done to that individual, that individual didn't necessarily ask for. And once you get to know your individuals who do engage in self-harm behaviors, a majority of them will have some sort of trauma history. All right. So here's some warning signs of self-harm. So again, down at the bottom of that slide, there unexplained wounds, scars, or bruises, frequent reports of accidents or clumsiness, blood stains on clothing, discarded tissues, sharp objects or cutting that are in the student's belongings, writing, journaling, drawing about self-harm or emotional distress, isolation, irritability, and also personality changes. Oftentimes, I'm gonna kind of flip back and forth between suicide and self-harm, but I think a common theme here when you're addressing or just having that first contact, whether it be with a patient or a client in a therapeutic setting, get comfortable with asking the question. And just because you ask the question doesn't implant the thought into somebody's mind like, huh, maybe I shouldn't consider engaging in self-harm. Get used to asking the question, do you engage in any self-harm behaviors? Have you thought about suicide? Just get used to kind of normalizing that. So oftentimes I get this question like, why do people engage in self-harm? Like, what would cause somebody to do that, especially for an individual that has never engaged in self-harm? It might be difficult to relate. So I like to categorize these things into two categories, intrapersonal functions and interpersonal functions. So intrapersonal functions, um, are what it does for yourself, right? So oftentimes, ask like, hey, what does this do for you? And or what leads up to you engaging in the self-harm behavior? Some people report like feelings of guilt, self-punishment. Also, people feel like as if they have a hard time regulating emotionally, that this helps them. Sometimes individuals have told me, like Ryan, focusing on the physical pain is much easier than focusing on the emotional pain or turmoil that I'm dealing with. All right. And then on the right, what are some interpersonal functions? What does it communicate to other people? There's a very distinct difference between if you see an individual with short sleeves and they're open, right? Like it's like, hey, this is who I am, versus an individual when it's 80 or 90 degrees outside and they are in long sleeve shirts and you wouldn't necessarily know. So that could be a distinct clinical difference of do I want people to know about this or is this a very private matter? And I think, there's individuals that I've worked with in the past where, you meet them in the waiting room and it's pretty obvious that they engage in that type of behavior. And there's also individuals that I worked with where they do engage in non-suicidal self-harm and I would never have known it. And that tells me something, right? Are you open about this or is this a very private thing? Cornell has a really good research program on, self-harm, functions for self-harm, help for self-harm. And I've linked the website towards the end of my slide deck here as well. Again, these intrapersonal functions, regulating overwhelming emotions, self-punishment, anti-dissociation, anti-suicide, right? Like they'd rather maybe choose this route instead of ending their life. They're unable to put their feelings into words. And look at that percentage. They reported that more people are engaging in self-harm for intrapersonal reasons. And then some interpersonal reasons, right? Uh, Communicating distress that's hard to verbalize, letting others know that they're in pain, seeking connection. Sometimes what I've seen is kind of some groups of individuals kind of unite around, well, this individual knows what I'm going through because they're engaging in the same type of behavior as well. The important thing here is I'll try not to get on a soapbox here, but so often when we're working with individuals, I feel like we like to put people in boxes. Okay, here's people that engage in self-harm, and here's the treatment for that. I'm more of a subjective guy. Ask the individual, what does this mean to you? Right? And it's going to be very different person to person. Again, that's just my perspective. So now, using the Q&A functions, client discloses that they self-harm. Now what? What are your thoughts, reactions, approaches? You can use the Q&A function.
Thank you for sharing that with me. Can you tell me more?
Gold star right there. You took the words out of my mouth.
You don't judge,
Absolutely.
safety planning.
Okay. Yep. Absolutely. What can we do to help keep you safe? Okay.
Thank you for trusting me.
Yep. Absolutely. Absolutely. Also, as a reaction, and for somebody who's worked with individuals and currently works with individuals who engage in this behavior, when you ask the question, the response is yes, I do engage in that. I think it's also normal to have the, oh, geez, type of reaction as a provider, right? It's okay to show concern. So again, some of you took the words right out of my mouth, right? Like, thank you for telling me about this. Oftentimes, individuals don't tell providers about these type of behaviors because of the stigma associated with it. And I think it's important when asking not only about suicide but also self-harm is to thank that individual for feeling comfortable enough to talk to me about this. So these are just some follow-up questions that I like to use. Was this done with the intention of ending your life? And that will give you a lot of information. Sometimes people will be like, oh, no, Ryan, no, not at all. Sometimes people might say, well, yeah, I think it was. Where do you self-harm? Again, this gives you a lot of clinical information, right? Self-harming here looks very different than self-harming. Some people self-harm on their thigh, And again, those are the individuals that I would never know engage in self-harm. And that gives me a lot of clinical information about how personal this is to them or how open they are about it. Really like this question. Have you ever been on the verge of self-harming and stopped? And if so, what stopped you? It's very different if an individual over here goes, well, my brother walked in the room. Okay. Versus an individual that might say, well, I'm thinking about giving up this behavior. Those can be two big distinctions. Uh, Even virtually, right? COVID has been kind of a blessing and a curse with being able to see our clients virtually. So how are you cutting, right? I'm feeling much more comfortable, even though I don't like it, with an individual cutting this way versus this way. This way is much more lethal. I met with an individual a while back, a client of mine, and he endorsed engaging in self-harm. And I just said, hey, if it's in an appropriate place in your body, would you mind showing me? And he's like, yeah, it's right here. Can you see it? And immediately, like I didn't say this out loud, but I'm like, all right, cool. The risk is much lower with that individual. And also, what are your reasons for engaging in self-harm? Like, what leads up to this? And that can give you a lot of information as well. And again, how interested or motivated are you to participate in therapy that might help with something like this? And also, this can be a very difficult behavior, especially for individuals that have been engaging in this for quite some time, to give up. All right, so why use DBT or dialectical behavior therapy? So comprehensive or CDBT has been studied and is well researched at reducing suicidal ideation and non-suicidal self-harm. And what we found is that the DBT skills components show effectiveness as a standalone intervention. So DBT or dialectical behavior therapy skills are well established for reducing deliberate self-harm and suicidal ideation. Now, what I tell students when I'm giving them presentations, and I hope that I don't like, even though I'm a big believer in DBT, I hope I don't paint it out to be gospel because there are also other modalities that are helpful as well. And also, the best predictor and outcome in therapy is your relationship with your therapist. So, some people have had really crappy therapists before, and I believe them, right? And also, sometimes I'm not the best fit for somebody wanting to engage in therapy. And so, a lot of it is we've got to find that right fit. So comprehensive DBT is a pretty intense treatment, right? Like we're looking at weekly skills group from 6 to 12 months, weekly individual therapy, phone coaching between that individual and their therapist, and the clinician is in a weekly DBT consultation group. And again, even when we were at UIHC, we didn't do comprehensive DBT because that phone coaching brings in another kind of complicated layer. And not a lot of individuals, not a lot of therapists want to kind of put themselves out there again for liability purposes, which I think makes sense. So when somebody maybe is first entering treatment, right? And let's just say like, hey, Ryan, I'm ready to try and kick this habit. I'm ready to maybe not engage in self-harm. And a lot of times we talk about distress tolerance skills, or these are crisis survival skills, change-oriented intervention. And we use these distress tolerance skills when we're at that heightened emotional intensity of 75 to 100. Now, a lot of these skills I'm going to go over, which I might go over pretty briefly, are pretty elementary, right? And anybody, including myself, when I'm at that range of 75 to 100, my ability to think is out the window. So we need something quick, something simple that we can do to kind of dial down that intensity. So the crisis survival skills that we talk about in DBT that I'm going to go over here briefly are stop, tip, pros and cons, accepts, and improve. Stop is exactly what it sounds like. A lot of times we've had individuals like, hey, just envision a stop sign, take a step back, right? And if you can't take a step back physically in a situation, if you can't leave, kind of take a step back mentally, all right? Like, let's just hold on here for a moment. O is one of our mindfulness skills, observe. And this is where I want people to really slow down. What am I feeling right now? One thing at a time. What am I thinking right now? One thing at a time. What urge do I have? What are other people communicating to me? Go slow. And then in DBT, we talk about this area of wise mind, this wisdom within each person. And Hopefully, once you get through observe, proceed mindfully, act with wisdom, and choose which path you want to go down. Do you still want to engage in that self-harm behavior because people do have free will, right? Or are you ready to kick this to the curb for now? And that doesn't mean that that emotional intensity might not come back again. The tip skills, these are some of my favorite skills. So, because when done correctly, they engage the parasympathetic nervous system. So, again, the autonomic nervous system that runs from the base of our brain up and down our spine controls a lot of things. And the two major parts are the sympathetic nervous system, the fight or flight response, which we all have naturally ingrained in us, and the parasympathetic nervous system, your rest and digest response. Again, these are biological, they're hardwired. And when these skills are done correctly, they will engage the parasympathetic nervous system. Again, your rest and digest response. So TIP stands for temperature change, intense exercise, paced breathing, and paired muscle tension relaxate. Paired muscle tension with relaxation. So the temperature change, when we used to do DBT groups in our partial program at UIHC, we'd bring basin bowls of freezing cold water to group. And one of my former mentors, she's like, "We're going to do it right along with the the group members. We bend down, get our head below our heart, and submerge our face up to our temples for around 30 seconds." It's kind of funny. I laugh because Karen would come up and all the makeup would be melting off her face. It didn't matter. She was going to do it right along with them. And what I noticed when I did that was when my face was submerged in ice cold water, it was painful, it hurt, but I wasn't thinking about anything else, right? And then the immediate after effect, I was just, oh, my body just felt like jello. Now, oftentimes people are like, well, I'm not walking around with a basin of cold water all the time. Of course you're not. You know, we all deal with teens and some of that, kind of back and forth. This can be done with an ice pack. I had a woman in one of my groups who was on the autism spectrum. She carried around a bag and she's like, I don't know when I'm going to become dysregulated. So she had these snap packs that would become cold instantly when you snap them. You can get them at like a CVS or a Walgreens. And the key is just snapping that, putting your head below your heart and moving that around your face. Now I have these asterisks, right? Like if your patient or individual you're working with has a heart condition or is engaging in eating disorder behavior, do not recommend this skill. Typically, people who engage in eating disorder behavior have lower blood pressure, and we don't want to lower it further, right? We don't want people falling fainting. Also, do what's appropriate for your site as well. Intense exercise, again, it's not the exercise itself. We're expending that physical energy in that moment, and then the after effect of a good exercise of just, right? Paced breathing, again, we want people breathing from their belly or their diaphragm. Oftentimes, in DBT, we don't ask people to do things that we're not willing to do ourselves. So sometimes I've had people come to me in panic, and I'll just say, hey, if you trust me, could we just sit down with our feet flat on the floor, put your hands on your belly or your diaphragm, and I want you to breathe in through your nose through the count of 5 and out through your mouth to the count of 7. And we'll sustain that breathing very slowly, very deliberately for 2 to 3 minutes. And the key here is if you see your patients or your clients start to yawn, you say, hey, that's how you know it's working. And tip has two parts, two P's. So pacing the paired breathing with the muscle tension relaxation. So again, we're pairing up tension with the breath in, let go of that breath, let go of that muscle tension on the way out. And you can do different muscle groupings with that. All right, so here's the pros and cons grid when thinking about a problem behavior. So, I'll throw that out there to a group, right? Like this top left portion of this box. Hey, what's a pro of acting on your crisis urge? A lot of times people are like, it works. It helps me get through the moment. It helps me deal with emotional intensity. Okay. Shifting over to that top right box, what is the con of acting on this crisis urge? Well, now I have to hide my scars from mom and dad. Now people are worried about me. It can lead to poor health outcomes. This might become a problematic thing, a crutch for me. Going down a row, what's a pro of resisting a crisis urge? I can learn more skillful behaviors. I don't have to have people concerned about me. I don't have to be covering up any scars, right? And then that bottom right box, this can take a little mental gymnastics, right? What is the con of acting on that crisis urge? Or con of resisting the crisis urge? And the common response is, it sucks. And yeah, it does suck. Think about sitting in distress and not acting on an urge. So I had some success working with a college-age student in the past using this pros and cons grid. She kind of upped her self-harm game from cutting to burning. She, was starting to get a lighter as hot as she could and putting it into her arms. And what we found was that attending this certain class that did a body scan for her was very triggering for her. And so we filled out this pros and cons grid when she was calm, cool, and collected. And then we brought it back out when she was about to go to that class. And after some time and with some practice, this helped her get through the moment without making things worse. We talk about behavioral extinction or harm reduction. Sometimes people have kind of critiqued me a little bit over like certain replacement behaviors, right? I'm going to talk about some of these shortly that I've had success with. Uh, and also, like, if people are ready to move forward, and I think this was a question posed earlier, like, how do we celebrate, like, how somebody celebrates sobriety, right? Like, let's celebrate this, and also let's try to let go of judgment if there's a relapse. Oftentimes, I've heard some younger individuals talk about, well, it's been 6 months since I've cut last. Well, great. And also, don't put too much pressure on yourself, right? Because if this does happen because we're human and we're emotionally prone, life happens, right? What have we learned from it and how can we best move forward? So I've had success with individuals holding ice. One individual that I'm currently working with, he's been fairly successful for quite some time, and now he doesn't even have to hold the ice anymore, right? We've learned some other skills, and he's been very skillful in other areas of his life, that he hasn't had to use it. But I'd much rather have somebody be holding ice than cutting themselves. Accept skill. These are all distraction techniques. What are different activities? What are ways we can contribute? How can we compare ourselves to maybe how far we've come? How can we distract ourselves with different emotions, like using YouTube is a wonderful example. Pushing away. Sometimes people talk about putting things in a box for now with different thoughts and with different sensations, like loading kids up with different type of sensory type of activities. Now, again, in the DBT manual, they give many different examples of what people can do for activities, for contributing, for comparisons in the Linehan manual. So there's lots of them there. Again, and I'm going to talk about this here briefly, but studies have shown that if individuals can engage in something for around 15 minutes, that emotional intensity has gone down enough that they're easier to sit with that discomfort and not engage in the self-harm behaviors. So improve is another set of skills from DBT. So the improve is an acronym for imagery, meaning, prayer, relaxing actions, one thing in the moment, vacation, and self-encouragement. So again, there's many different examples that Linehan gives under each one of these subcategories. Now, you see the word prayer in here, and that can be kind of a hot button topic, especially if you're an individual that goes and works in schools. Now, I'm an individual that plays on somebody's strengths. If their religion or spirituality is important for them, great. And I'm going to utilize that, but I'm not pushing religion on anybody. I worked with an individual who had schizophrenia, and he talked about having some really compelling delusional thoughts. And he was a devout Catholic. I'm not a devout Catholic, but he talked about using the rosary and handing his thought over to God as being helpful for him. That was his strength, and we utilized it. Again, those of you that work with youth, this is a pretty common theme. 5, 4, 3, 2, 1. The key is go slow, right? Like, hey, buddy, what are 5 red things that you can see right now? And it doesn't necessarily have to go in a certain sense or a certain order. But the key here is to go as slow as possible with this. And also worked with individuals before that are on IEPs 504s, right, in school and can become emotionally dysregulated, that they're able to use a different room or place. Part of my job that I feel like is going through some of these sensory things with individuals and communicating that if agreed upon by the family to that teacher so that we can load all sorts of sensory things up for that individual to re-regulate. My kids are into these squishies and neatos right now, kind of the craze. So this was an interesting article on self-harm, and I kind of alluded to this earlier, right? And I think this is really powerful. When feeling the impulse to self-injure, commit to waiting 15 minutes first. Use this time to try alternative coping strategies that we've just talked about too for 15 minutes. And after the end of that 15 minutes, can we decide, okay, do I still want to commit to not engaging in this self-harm behavior? Or as some people do who have free will, do they end up engaging in that behavior? So now we've just talked about change-based strategies, right? The stress tolerance is all about what can we do? And now we're going to switch gears a little bit and talk about acceptance based strategies. And I really like this quote by Linehan. Perhaps nowhere is the ability to empathize with another person more important than when one is interacting with another individual who is on the brink of suicide. So validation to me just means being human and being able to communicate to that other individual that they're in pain right now and it makes sense that they're in pain right now. Um, so some people see, I don't think validation is not doing anything. I actually think sometimes it's very important thing to do. And can this lead to a path towards changing some behaviors? Again, we're communicating that people's responses make sense and are understandable given their current context or situation. Okay. So things to remember is that validation is not agreeing, it's not complimenting, it's not reassuring. Now, as a parent, right, I want to reassure my daughter everything's going to be okay. And what if it isn't, right? Like, what if she interacts with somebody at school that, is invalidating to her? So again, we're saying that things make sense and we're not necessarily agreeing, complimenting, or reassuring. So Linehan talks about these six levels of validation, and she's got a really good article on these six levels of validation and really expanding them. And I don't want people to think about these as like Maslow's hierarchy of needs. I think each level is just as important as the other. Level one, something as simple as listening and paying attention. We live in such a distracted society, right? Like even right now, I've got two screens, my cell phone, things can go off at all times. I'm putting that aside and I'm paying attention to what that person is saying, just being 100% with them. And oftentimes, I'll even use myself as an example. My wife has a very stressful job. Sometimes she'll come home from work and she'll be talking about some stressful situation that she encountered. And I go into problem solving mode, right? Like, oh, did you talk to your boss about that? Did you tell that person how you felt? Did you send them an email? What can we do about this? And she's more like, no, I don't need any of that. I don't need you to fix it. I just want you to listen right now. Oh, duh, right? You're a therapist. You should know this stuff. And even sometimes I lose sight of it as well. Accurate reflection, right? So we're reflecting back to the person what they said and using their own words. That makes that individual feel heard, feel seen, and it shows them that you're actually paying attention to what they're going through. Articulate the unverbalized, so reading minds, right? So kind of be careful with this one, but like, hey, given what you're showing me, your words don't really match like, some of the nonverbals that you're showing me. Or once you get to know that person, if I was in your shoes, I think that might make me feel angry, upset, whatever the case may be. And sometimes I lead into correct me if I'm wrong, because I always give the individual opportunity to correct me if I'm wrong. All right, validation in terms of the past, right? Like, given what you told me about your past, it makes sense that you'd want to engage in self-harm again. Given what you told me about that interaction that you had with that teacher, that peer, your boyfriend, your girlfriend, that you might want to engage in that behavior again, right? So that shows that individual, not only are you listening to me now, but you've listened to me back then, right? And that really enhances that relationship. Validating as reasonable in the moment, right? Given that your boyfriend just broke up with you and left you for your best friend, it makes sense that you'd want to key his car. Now, I don't agree with that, but it makes sense that you'd want to engage in that type of behavior, right? And level six is just being radically genuine, radically genuine. Be who you are as a person and communicate that you're a person. To individuals that are getting their master's in social work, their doctorate in psychology, for some people, they're very like text savvy oriented, right? Set the book aside. right? Treat this individual like you treat your brother, your sister. Okay. Here's a validation cheat sheet. All right. So you're saying, I can see that that must have made you feel blank. It sounds like you were, right? And so these are just some things that can be kind of prompts when we're working on validation. Here's a validation exercise that actually they do in the adolescent DBT groups at UIHC, or they have done in the past, where they kind of separate two people and they pick some categories like, all right, this person's a dog person, this person's a cat person. All right, cat person, I want to say you say two things that you like about cats. Dog person, even if you don't like things about cats, how can you validate that person, right? Like if I'm a cat person, I like that I can go somewhere for the weekend and I don't have to take my cat and that they're low maintenance. And if the dog person says, wow, that would be nice if, or that must be nice if you have kind of a low maintenance animal that you don't have to take places. And if this person felt validated, they move closer to them. If they feel invalidated, they move further away. Now, not only is that teaching these individuals how to validate each other, right? Even if they don't agree, but it's showing the other people in group like what that looks like. Again, I put some kind of ones that might get into heated battles, so know your audience if you're leading groups, right? And maybe throwing some of these might not be a good idea out there right away. So now we're going to shift into some mindfulness skills. So I'll be honest with you. When I was first introduced to mindfulness, I'm like, oh God, here's this hippie stuff. But then when I started to do it and practice it, it started to make sense. And I try to implement it at least at some point throughout my day. Some days are better than others. So what Linehan does is she's taken mindfulness, which can be kind of this nebulous meta kind of concept, and she's operationalized it. So she's put these into the what skills or what you do to practice mindfulness, and then the how skills. So observing is just taking in information through your senses, right? And take it in one thing at a time. Describing is when we put words on the experience. We're describing the situation and removing judgment. I really like how she says describe the who, what, where, when, and that the why is left off of there. I try to tell up and coming therapists, try to remove the why from your vocabulary. Comes off as very judgmental. Well, why did you do this? Why are you thinking this way? Why are you acting this way? I feel as if oftentimes people are wide enough that they start to why themselves and give themselves that internal dialogue. Well, why am I this way? Why am I doing this? And that comes with a lot of judgment. Again, that's just my school of thought. Try to remove the why when interacting with your clients. And then last but not least, in the what skills is participate. Throw yourself completely into activities of the present moment. Be one with what you're doing and be effective. How can I participate in this class even though I don't like it and be effective and pass? A former client of ours said the participate practice is like doing the electric slide at the wedding, right? We're jumping in, we're going with the flow, we're being spontaneous, and we're also playing by the rules. So now we shift into the how skills or how you go about being mindful. And being one mindful, again, is easier said than done. Getting my two little girls out the door in the morning can be like an act of Congress. Like, where are your shoes? You didn't brush your teeth yet. Like, what's up with that? And it's just like, all right, Ryan, one thing at a time, right? It's just noticing that distraction, bringing ourselves back again and again and again. It's like teaching that puppy dog to sit, sit, sit again, sit again. Okay. And when we're linking these skills of what and how, observe what's going on one thing at a time. Okay. The next how skill is removing judgment or seeing things non-judgmentally. Now, we're not going to be like these non-judgmental blobs out there, right? Like we all have judgment. And what I've found is that we're just noticing this judgment, and if we can, trying to let it go. Easier said than done. So we're describing what's going on for ourselves and removing that judgment. I would argue that this is the bigger piece and where you're going to spend more energy and attention on in the clinical setting is how we can get these individuals that engage in self-harm, how we can get them to start not judging themselves. It's a big portion. And last but not least, being effective, right? Know your goals in the situation and do what is necessary to achieve them, right? So I work with a lot of high school age students. I hate my science class. The teacher sucks. Fair enough, right? Do you need that science class to graduate? Is that one of your goals? I'm not telling you to love your class. How can you effectively navigate this class and pass, right? They don't necessarily need to answer that question, but they should think about it, right? So, how do we participate effectively in what's going on for us? Now, with an individual engaging in self-harm, right? I'm trying to teach them these mindfulness skills. And again, DBT is all about, well, and a lot of therapy is all about practice, right? Learn them here, apply it out there, and apply it often. So after an individual engages in therapy, learns these what and how skills of mindfulness, right? I'm hoping that they can link them together, right? And after teaching these skills, life happens. People are going to encounter triggering situations that set off emotional intensity. Happens all the time. We don't know where it's going to come from. And this is life. So the skill here is using that stop skill, stop, take a step back, observe, proceed mindfully, and then linking up these mindfulness skills in a linear fashion, right? Okay, what can I observe one thing at a time? What's going on internally with me, one thing at a time? What's going on externally? What are my thoughts, one thought at a time? What are my emotions, one emotion at a time? What are my urges, one urge at a time? Then I'm going to shift to describe what's going on and remove judgment. Can I describe my thoughts and remove judgment? Can I describe my urges and remove judgment? Okay. And then finally, hopefully by then, emotional intensity is starting to come down. How can we participate effectively? Can I use some skills from TIP? Can I use some distraction skills? Can I go find a trusted person and talk to them about what is going on with me? And hopefully by linking these skills up, right, that they eventually don't engage in the problem behavior. And also, I pose the question, is engaging in self-harm, well, hopefully after this, is engaging in the self-harm the route I want to go? That's what I hope I want them to ask themselves. But also, if that individual comes back in the session, they're like, Ryan, I linked these up, I did them exactly how you told me to, and I still engaged in self-harm. That's not a failure. That's not a failure. That's actually a success, right? Because when you started treatment, triggering situation to engaging in the behavior, how quick was that, right? And how long did you last or use these skills moving forward um, to now? And, celebrate that. And also, but also we're pushing towards change. Now, when these situations come up, can you sit with this for 15 minutes, for 20 minutes? Can you use skills further and further and further? So hopefully that we don't engage in the problematic behavior. I think one really important thing as clinicians is that we use self-validation. Again, we're not asking somebody to engage in skills that we're not willing to use for ourselves. So also validating like that sucked. That was rough. That was a rough day. That was a rough group. It was kind of a simple thing, but actually kind of a light bulb moment for me when I was seeking out consultation. I was doing a group at the hospital, and there was this woman that if I let her, she would like commandeer the group and talk for the entire 2 hours. And it was so painful for me to be like, stop. And I was shooting myself. And in DBT, we say don't shoot on yourself. Like, gosh, why am I having such a reaction to this? I shouldn't be letting her get to me. And my supervisor at the time said, yeah, that is annoying. That would suck. And it's kind of like, yeah, that does suck, right? And so applying that self-validation to yourself, I think is just as important. If we're encouraging our clients to do it, we're going to do it for ourselves. Another important thing, clinical consultation, right? Don't if you're going to do this work, don't go at it alone. It's so important to seek out consultation when working with these high risk individuals. And not only does it provide like group cohesion and that we're kind of like in it together, right? Sometimes I might be missing something and somebody might have a suggestion of something that maybe I could be doing differently or something that I'm missing as well. It's very, very important to seek out that time and to seek out those peers that you truly trust and confidence and have those difficult conversations with to problem solve, but also to validate each other as well. Okay. So actually, I got through a lot of that quicker than I thought I would. But I've Coffee has a PDF of my PowerPoint. I've just linked some resources in here and that you can provide. So again, these are some more local, like Iowa City resources, but 988 or the Iowa Warm Line or Your Life Iowa, those are statewide. And also the mobile crisis map for people who are in crisis and, a good, resource for your individuals to use when they are in crisis and thinking about suicide or self-harm. So, um, I guess we can use whatever remaining time and hopefully I can answer questions that people might have.
Well, thank you, Ryan, for an
Yeah.
excellent presentation and all the valuable resources and tools you shared. We did have some questions already come in. One of the questions was, why do some individuals like to show the scars?
I've had the experience like sometimes people have like the woman that engaged in the burns, like they were like she would say, "This is a badge of honor. This is who I am." Some people like to share that they're not doing well. Again, that's just been my experience. For some individuals, they want the help. Some individuals, it can be like kind of this sounds kind of weird, but like a bonding experience, right? Sometimes we talk about social contagion where that sounds really bad and really judgmental term, but a group of individuals that engage in self-harm, like they can relate to each other. And so if I'm working with one of those individuals, I kind of take the pose of, okay, I can't tell you who to be friends with. I'm glad that you have friends. If you're willing to start working on giving up this behavior, can you still be friends with these individuals and work on not engaging in that? Is that in your wheelhouse?
Okay, thank you. And then there was a question about, what if they're not able to verbalize a reason um, for the self-harm?
Yeah, maybe they might not be there yet. Again, getting to know that individual. If it's a younger individual, maybe bringing in the family and doing some family sessions like, hey, mom, dad, caretaker, what do you see that leads up to this? And trying to do some problem solving. But even if the individual can't verbalize that, right? Maybe we'll get at some feelings, some emotions, like what do you notice before engaging in that? And when you start to maybe physically feel that sensation or notice that emotion, could we use some of these other distress tolerance skills to maybe help curb it?
Thank you. There were a couple of questions surrounding why this seems to be more popular or more prevalent.
Man,
Could this be due to environment or socialization, social media? Do you have thoughts on the
this is
prevalence?
going to go into the great unsatisfying answer of I don't know. But I'll tell you what, I was just on a news site the other day, and there was this celebrity blogger, Perez Hilton, and supposedly he was engaging in self-harm on a live stream on, I believe, TikTok. Again, supposedly this is the news. But I don't know if it's like more accepted now. It's used more as a alternative coping skill, but the trends are not going the way that we want them to go. I wish I had a better answer.
Well,
Social media can be a blessing and a curse, right? Like we can seek out resources for help. But also like is an individual that I'm watching or, creating content like encouraging stuff like that, that's where it becomes dangerous.
okay, thank you. Um, Someone asked or asked to hear more about your stop asking why approach. I loved it and have never heard it before. Can you tell me different ways to approach this in a session instead of asking why?
Yeah, absolutely. It can be kind of a mind game a little bit too when you're used to using that word. I just feel like the word why comes with a lot of judgment. Kids and I'm guilty of it. Well, why'd you do that? Well, and that just creates a lot of judgment there. Like, so I might take the approach like, hey, I'm really curious about this. Can you tell me what led up to what and how we got to this point? Right? That might be like a starter of like, Tell me what was going on and how we got to you engaging in this type of behavior. I feel like that just in my opinion just lands a lot softer. And I'm just always trying to be aware of not judging an individual across from me. Hopefully that helps.
Thank you. Any ideas on how to help a client find identity outside of self-harm? Example, there's a lot of identity connection with the scars, which leads to more self-harm urges when the scars are fading.
Yeah. The immediate thought that I have is one of my favorite therapy one of my favorite things to do for homework in a therapy session is I want you to go have fun. I want you to go do something that you enjoy. Obviously, that's not problematic and be mindful of that experience, right? Like that doesn't sound like earth-shattering, but if somebody is doing that like every single day, right? And identifying hobbies or doing things that they enjoy every single day, it's like putting metaphorical change into emotional savings bank. Like initially, it's not that much, but if we're feeding that savings bank over a year, right, we've got a lot to withdraw from. So every single one of my clients, they know it. What are you doing for fun? When are you going to do it? Can you see anything getting in the way? How mindful of that experience can you be? Kind of a tangent. My mind kind of goes on tangents. I asked a client of mine leading up to this presentation, what do you want people to know about self-harm and what has helped? And he said, I don't mean to laugh, but what he said was it causes people to become concerned about you, which is a blessing and a curse. And then for him, I said, all right, what's helped? Because he's been pretty successful. He's said my connection to my friends has been helpful. So that's not unique to DBT. That's just life. That's being a human being.
That's great insight for your patients. When a patient divulges self-harm, how would you suggest we address this with the parents, with the
Ooh.
patient's consent?
That's where it gets tricky, especially when working with minors, right? I don't want dad to know. Don't want mom to know. Man, that's going to look different situation to situation, provider to provider, and how comfortable you are. You also got to think about your agency policies, stuff like that too. You know, there can be a spectrum of providers where, okay, maybe this stays between you and me, and if it gets to a certain point, when do I rope in mom and dad? There might be some more conservative type of providers where, all right, I have to let mom and dad know. There might be some people in the middle that might say, okay, thank you for disclosing that to me. How do you feel about having that conversation with mom, dad, provider, right? Would you like to do that alone outside of session? What's that going to look like? Can we practice it here? Would you like to invite mom and dad in here and we can have that conversation together? Um, that's a tough one. I mean, that's going to look different all the time, but I hope that some of those suggestions may have been helpful.
Thank you. Is the treatment protocol for individuals with developmental disabilities or intellectual disabilities similar?
That's a great question. I think with just where my gut goes with somebody with like an intellectual disability, I want them to know, like, I want them to know like kind of why, I'll use why, the purpose for using the skill and what it's to help with. Hopefully we're giving individuals coping skills and replacement behaviors so that maybe that they're not engaging in self-harm. And if it's an individual maybe residing in a group home, a lot of maybe some of your job is to coach those individuals who are the day staff, the night staff, when you see somebody ramping up, how can we give them a sensory object? That's just my initial thoughts. What do they go to cope, you know, and trying to utilize that and trying to get that kind of wrap around that individual so we're helping the people working with that individual use it in real time.
Thank you. Here is a comment about, um, well, they say, I work in mental health and support patients who might engage in self-harm, but I'm not a licensed therapist. I sometimes struggle with how I can intervene and support in my role. especially if a patient is actively engaging in self-harm?
That's
What
a
are your
great
thoughts?
question. Yeah, DBT, dialectical behavior therapy, it has that term, therapy at the end, right? And I don't think there's any harm in suggesting and practicing skills, right? A lot of DBT is basic psycho ed, is skills. Current colleague of mine, we used to do the DBT in schools training where we would train guidance counselors, support staff in schools on the skills and how they could teach these skills to students. Now, they're not licensed providers, but they're learning the skills, how to use them, and they're conveying that on to the students that might be in distress. Personally, people can disagree with me on this, but I don't think there's any harm in like recommending a skill or coaching or teaching a skill.
Thank you. I appreciate that. Tips or ideas for supporting caregivers in
You
checking
know,
in with their kids regarding self-harm events when they find it annoying or like now everyone is babying me or
I mean, I think validating them as well, right? Like no parent wants to have a child that's engaging in self-harm and like it sucks for them as well. And I think just trying to incorporate them, if you can with treatment, if you're recommending a skill and like let's say the client's brought on or bought on to using this skill, um, talking to the parents, sending them handouts saying, hey, this is what I talked about your kid with in session. And then also, like, kind of in line with PBIS with our elementary age kids, like, catch them being good, catch them doing the right thing, right? And helping them at home. Like, I see that you were in distress and that you were using this skill. I'm really proud of you for doing that. So, identifying points of pride in time when have been able to be skillful.
thank you. Can you explain more about the 5, 4, 3, 2, 1 method?
Yeah, so sensory, again, sorry, I probably went through these pretty briefly. But using the senses, right? The five senses, what we can smell, hear, taste, touch, and see. So there was an individual, COVID was a wild ride, wasn't it? I was seeing a client in California and she called me. She's like, Ryan, I witnessed this horrific car accident. I'm having, she's in panic. And I said, pull over the car, right? We're going to talk. And hey, what are five things you can see right now, one thing at a time? What are four things you can hear right now, one thing at a time? What are three things you can touch right now, one thing at a time? Two things you can smell, one thing you can taste. So that's the 5, 4, 3, 2, 1 technique. Again, often used with kids. I've used it with adults and had success too. But also mark what sense is the most grounding for that individual. For some individuals that have been through some serious trauma, what I've seen is certain smells really set people off in a bad way. Great thing, avoid that. Don't do it, right? There's other senses that we can connect with.
All right, thank you. Well, I think we covered a fair amount of the questions. I appreciate all the wonderful questions that came in and the discussion. And as we approach 1 o'clock, I'll close with um, a few housekeeping items. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, social workers, and physician associates. All other participants will receive a certificate of participation. Attendees are eligible to claim continuing education credit by completing the evaluation and downloading their certificate of participation. The instructions for how to claim credit. I'm sorry, I forgot to attach it to the chat. I will send that in the follow-up email after the webinar closes. For any questions, please feel free to reach out to me via email at coffee, K-A-F-I, -dixon at uiowa.edu. And so in closing, I just want to thank Ryan for presenting on this important topic, and thank you all for joining us today. And have
Thank
a
you.
great afternoon.